Good evening, good evening, everybody. Before we begin, I request a moment of silence for the victims of tragic plane crash in Ahmedabad. As someone who belongs to that city, my eyes were really filled with tears, and it is really last 2 days as very heavy heart for me. And we cannot actually imagine even the amount of pain which the loved ones have got. But the least we can do is offer our heartfelt prayers for their peace and healing. I request 30 seconds of silence. Thank you. And with that prayer in our hearts, we move ahead. So let us begin today's MDM with same sense of purpose and responsibility that this moment has reminded us of. And I will just start sharing my screen. It's visible, right? You can see my screen, right?
Yes.
Yeah.
Yes,
Okay.
yes.
Okay. So first case, there are 5 cases. We have got, even though we have 2 cases with pathology slides, unfortunately neither Ritu madam nor Sharda was available. So what I have tried to do is I have tried to incorporate the comments of madams in the slides after the slides. So I have changed the presentations in a way that we can get their inputs, and we will incorporate pathologist comments. We have got rheumatologist as a Mithun, and we have got radiologist as Aparna, and today Murli Mohan sir is not available. Atul Wells is not available. We have got Rajan sir and Prahlad Prabhu Desai with us as a pulmonologist expert. There are 5 presentations, and we will start with my case first. So this is an interesting case. All my cases you might find that it is so easy, but I really find something to discuss. So that is why I'm presenting. So 64 years old man. He has multiple comorbidities like hypertension, diabetes, dyslipidemia, chronic kidney disease, nephropathy, retinopathy. Now, those 2 points I will come little while. That how come he has developed this nephropathy and retinopathy with a well-controlled diabetes, and in intervertebral disc prolapse, neurogenic claudications, lumbar canal stenosis. He is post CABG in 2017. He's 64 now, and almost 7 years before that happened, and those details I will just skip because it is not relevant. Now, when I saw him this time, he presented to me with cough, breathing difficulty, and fever for last 4 days. It looked like a viral prodrome, like running nose, generalized tiredness, abdominal discomfort, and loose stools. Almost that was the time when the COVID started rising in Kerala. So one month before, I think he came to us. When he came, he was slightly hypoxic, 94% room air saturation, and BP was okay. Respiratory system examination, nothing significant. Now, this investigations, there are something which was very relevant, and that was his total CK was very high when I saw him first time. Along with that, he had ESR elevated, he has anti-CCP which was normal, creatinine was always on a higher side even before this incident happened, and C3, C4 were normal. If I remember correctly, his CK at the time of presentation was 3600, and that is when because he was my follow up during COVID, first COVID in 2021 also I saw him. So that is how he landed up with us. Now his baseline creatinine before this CK went high was around 2.5, which went to 3.5. That is the time when we saw, and the other investigation CCP, MPO, and everything I had sent later on after seeing his CK level was very high, because we thought why the CK is high. So these were the investigation which came afterwards. Now, before we move on to this investigation, I would like to give you information that as soon as I saw his CK was very high, we started conservative management with proper fluid intake and by the time he got discharged, his CK went into 1000, and then maybe around 200 or something was the time when I discharged him. So CK was related to current viral infection. But anyway, I had sent this ANA profile, and I would request Mithun to just go through this ANA and myositis profile for us.
ANA, basically, it's a low titer SL70 and PML. Basically, this is scleroderma spectrum of antibodies. Significance, there is a low titer antibody positivity. And
Okay.
myositis,
Yeah.
but there is also 1 plus, no? Multiple antibodies are
Yeah.
positive. That
Multiple.
may not
Only
be.
thing is this SCL 100 was positive in both, and both it was 1 plus, Mithun. Still, you won't take it significant because
Uh,
both
the,
are
uh,
consistent, na?
this may not be false positive, but this may not be significant. The
Okay.
antibodies may be there, but how significant it is if CPK is coming down without any
So you don't think it is
immunosuppressant?
myositis?
No,
Yeah, yeah,
no, no.
yeah. We didn't give him steroids. Yeah, those of who were thinking, yeah.
PMSL is basically is a overlap syndrome, usually associated with myositis, high CPK.
When will you say it is high? Because this is
2
20.
plus, 2 plus and above.
Okay, so anything 2 plus and above, if it
It's
was in, yeah.
significant.
So in this case also, if it was 2 plus, you would have considered significant, but not now, right?
Not now, but 1 plus also sometimes we have to take significant if clinical history is very typical for that
Okay,
disease.
okay. But in this case, because CK came down by itself, you are
Yeah.
not thinking. Yeah, okay, fine. So this is his spirometry, and I have included 2021 because that was the time. So now coming to that COVID, he came to me in 2021 September, and if I'm not mistaken, I have included X-ray of that. I gave you X-ray, Aparna. We have X-ray, then you show that also. If not, then it's fine. So 2021, he was admitted. He already had diabetes and CKD that time, and he required ventilation, and he was very bad COVID, and he recovered from that. That is a 2021, and that is the time when he had this kind of reports of 36% of 49% of FVC and 56%, which in June when he came to me, which he recovered very well. There are no problem in the spirometry side as such. And with that, I will stop sharing my screen. He recovered from the current viral infection. That is when I did my spirometry in June.
So what was the spirometry in September 21 done for, Smita?
He came just post COVID, sir. So we did it for investigation of his baseline lung function and all, because he recovered from almost ARDS COVID and all. We wanted to see.
Ah,
Okay.
okay. So it was almost an ARDS like COVID.
Oh yeah,
Okay,
he was very sick. He had CKD and diabetes, both risk factors during 2021.
sure.
So this was the 2021 CT where we can see there's quite a bit of involvement of the lungs, and it is looking like the usual typical COVID with multiple peripheral areas of ground glass and consolidation. Some areas are like the crazy paving like appearance. And this is the present CT. So definitely most of the findings are kind of in the same similar areas. Like for example, if you take this, that area has become better, but little bit of reticulations are there in that, and some inhomogeneity is there. So I guess he's having probably some kind of obstructive airways disease, whether it's post-COVID, I'm not sure. So
Mm.
some sequelae are there probably from his previous COVID. But now he's also having some ground glass, which I think is correlating with the recent viral illness, which I think is probably not his background. But in the
Yeah.
background, I guess little bit of post-COVID changes are there, plus maybe some obstructive airway like changes are there, but
Oh,
nothing to suggest any other type of, like not our usual CTD ILDs and all, nothing like that is there.
sure. So I think I have. Yeah, if you stop sharing, I have question for a radiologist, and I have separate question for our consultants. So do the serial CT scan suggest progressive fibrotic ILD or stable post-COVID sequelae? So, Aparna, this is my
Yes.
valid doubt that and I think Prabhu Desai sir and Rajan sir also can help, because they also had seen plenty of COVID during that time. And Bhavin sir also usually tell that during COVID time also there were two kinds of people. One who developed severe COVID and recovered completely, and their radiology had shown some changes, while there were few people who developed severe COVID and their radiology also completely recovered. And there were one group of people who actually worsened, and they still continued to have LTOT requirement and all. And in those cases, even I had read many trials also, which says that there was pre-existing ILD in those patients, and that was just diagnosed because there were so many CT scan done during COVID time, and that is how they came to know that this. So, is there any way we can say that this particular the previous CT of 2021 is only secondary to COVID, because we do not have any baseline, right? So there is
Yeah.
no way we can say that it was not existing before, right?
Yeah, but I think in his CT there was nothing really to suggest any fibrosis. It was all looking
Okay.
like the acute changes, and it was looking like the typical COVID. I don't really think he had anything underlying at that moment. And I think now again, I think he has some post-COVID changes, but I think he has a overlying acute changes also, because he has now presented
Viral
also within
infection,
one.
yeah.
Maybe we should just repeat one after 6 weeks or 2 months or something, just to see what his actual baseline is, so that we know if we are following him up, if something is actually progressing or not. Because now may not be a good baseline for follow up. In case we want to follow him up,
Yeah.
we should have a proper baseline after 6 weeks to 2 months. Maybe you can repeat one.
I think so, because I actually didn't remember him correctly, but I was looking at his all X-rays all this while, and X-ray was not showing any change, and suddenly he ended up with another viral infection. That is what happened, and that's how it came in a picture. And my other question, Mithun already answered that. Given the significantly elevated CK, do you suspect occult myositis spectrum disease, even with like not inconclusive myositis panel? That is one. And for our Rajan sir and Prabhu Desai sir, would you monitor this as a post-COVID fibrosis, or should we do further workup, anything for uh, CTD, ILD kind of things, or should we do something, or just I should monitor as Aparna told?
Yeah, Prahlad, you want to go?
I think just monitoring is required. Only I will be careful about so much very high ESR 107. I don't know what is the reason.
Yeah.
And probably the baseline saturation, what you have shown is 94% at moment. Okay, which is also maybe underlying chronic kidney disease and so many factors which patient has. Okay, maybe contributing to some extent pulmonary changes, restriction, and other thing. But certainly, repeat scan may not be required, but clinical manifestations we should look for, and if required, lung function test, 6 minutes walk test may be more useful than scan.
I agree, because as sir rightly pointed out, now the ESR of 107 I can't explain. And even though his CK, total CK from 3000 came down to 170 on my last follow, CRP was still 27. And that is where what was making me worry, that something else is going on which I am not able to identify, even though C3, C4 was also normal. So I have asked him to come for review after 1 month with CBC, CRP, ESR, at least for the repeat. And as of now, I didn't start him on any treatment, like, because he was doing quite well, except that. And his diabetes, like coming to that diabetic nephropathy and retinopathy, his HbA1c is 5 point something. He's on very well controlled diabetic regimen, and all these complications happened at the time he presented with kidney failure. So then I was thinking, is it vasculitis which was causing all this problem? And that is why anti-PR3 and anti-MPO was sent, which came negative, because his presentation itself was with a kidney failure, and they labeled it was a diabetic nephropathy. Then retinopathy also happened. So there are many things which are labeled, and whether it was really there or not, I'm not sure. But present case was only for, because is it COVID fibrosis or just going on? And you felt Aparna it's improving, right? The the COVID pattern.
Yeah, I mean, definitely it has improved from the first CT, but that was like
Still there, yeah.
4 years ago. But I think he has some post-COVID changes, definitely.
It's
I
there.
don't think everything
But
now
it's
is
not
active.
progressing, right,
No,
Rajan
no,
sir?
no, nothing is
Yeah, we
progressing.
don't have to do
In
anything
fact,
from
it's
your side.
improving.
Yeah.
It's actually improved.
Yeah, it's
Shweta.
improved. It's
You've
improved, yeah.
gained about 1 liter of lung function.
Yeah.
I think your DLCO, there is some problem on your second test, because it's some 100% DLCO.
I know.
It's a
I think
little odd.
we have to check it again. Yeah.
That you
I'll
need
check
to
it.
check.
Yeah.
And I think, yes, you said he's got some airway disease also. on the scan, I think Aparna mentioned something about a bronchiolitis. What were his lung volumes?
I will show you. One
Total
second.
lung capacity was not very high, was it?
Oh, it's very good. In fact, 7 liters something.
Yeah.
He is very healthy as such. His weight and everything is fine. This is what he was. Yeah.
Yeah. So his lung volumes are high, which means that definitely got an airway component,
Yes.
which anyway Aparna pointed out. So you may just want to give him a bronchodilator right now, long
Yeah.
acting.
I think ICS LABA is on. He is on that for a long time.
I don't
I'll
think
continue that.
anything more in monitoring of lung function and maybe check the ESR. He's got a lot of comorbidities.
Yeah.
So ESR could be, there's the spine, there's the
Yeah.
heart,
He has lumbar stenosis. Yes.
diabetes. So
Mm.
there may be more to that ESR than just the lung.
Yeah, I think Lakshmikant has written that GGOs with peribronchial involvement, possibility of recurrent secondary OP. But because he's improving, his saturation is improving, I'm not going to address even if it is OP kind of features. And
Sure.
I would go with your suggestions to go with the observation and if required CT scan repeat. I will do a quarterly PFT. That's okay, na sir?
Yeah.
Yeah,
That's right.
okay. Yeah, I'll move on to second case and we finished first case in 15 minutes. That's good thing. Second case is Dr. Shobha, who is a professor and head of Department of Pulmonary Medicine in Amrita Hospital. And over to you, ma'am.
Hi, good evening. This is a case of 68-year-old female from Chertala. She is a homemaker now, but she used to be working with the coir factory till 15 years back. No comorbidities. And she has a past history of being evaluated with bilateral bronchopneumonia with ARDS and was hospitalized, not ventilated, from 27th of Jan 2016 till 5th February 2016. She had an acute febrile illness, following which she developed progressive breathlessness and hypoxia, and she recovered completely from that. I think I have given the CT chest. Should we see the CT now or later?
We'll
We
see
can
together,
discuss
na,
it.
ma'am.
Yeah,
Yeah, we'll see
that's
together.
better. So this was her X-ray in Jan 2016. In April, the whole thing has completely subsided and she was perfectly asymptomatic. But she followed up in the Department of Medicine in 2017 when she was asymptomatic, but X-ray I thought was not normal. And now she landed up in the pulmonary medicine OPD last month with a history of cough with scanty whitish sputum for the last 1 year. And she has a shortness of breath, which has been progressive for the last 1 year. It has progressed to grade 3 in the last 3 months. And she also mentioned because of the violent cough, she had 2 episodes of blood thin sputum about 2 weeks back. That was in April. Additional history of exposure. She has exposure to biomass fuel for a long time until 8 years back. And she is exposed to pigeons in the just neighbor's house for the last 4 months. And she is on bronchodilators. There is no history of any joint pains, no loss of weight or a loss of appetite, no other symptoms. Examination 96 on room air, heart rate, blood pressure, all, but she had grade 1 clubbing, and on examination there was bilateral squeaks and crackles throughout. And this was her X-ray when she presented to me, which is showing bilateral reticulonodular shadowing involving the mid and the lower zone basically, with near normal lung volume, I would say. And the CTD workup showed rheumatoid factor, anti-CCP, ANA-IF, all negative. And this was her lung function, which showed FEV1 of 53, FVC 58, with a ratio of 87. DLCO was pretty low, 20%. VA 63%, vital capacity 50%, TLC is reduced to 53%, and she desaturated on 6-minute walk test with 95 going to 74 with severe dyspnea. Her echo showed ejection fraction 60% and no PAH. And her CT, yeah.
Somebody from the audience is commenting that they cannot see the slides moving. You people are able to see the slides moving, right?
Yeah.
Yes,
Okay.
yes.
Okay.
So we have two CTs. This is the 2016 CT when she had the ARDS. Just before I go to the lung window, I just want to point out at that time she had some left axillary lymphadenopathy. The size was around 13 millimeters. Just look for any breast lesions. There were no lesions in the breast and no other significant adenopathy, right axilla, mediastinum, etc. Then she had bilateral pleural effusions and minimal pericardial effusion was there. The lungs at that time showed the typical changes of ARDS, multifocal consolidations were there, more in the upper lobes. So that was kind of fitting with the clinical that you gave me. So
One
now,
second, Aparna, I'm sorry to
yes,
interrupt you.
yeah.
I think many people are messaging me. Manish, can you please check what is going on the audience side? They are not able to see this. Can you please take care of that? Manish, are you there? Okay. Aparna, you go on. I will call him. It's okay.
Okay, sure.
We should call Manish, Asmita.
Should we hold on or?
I think just wait a couple of minutes.
Okay, sure.
Just wait a couple.
Sure.
Akshay. Akshay, are you there? Akshay. Hello? Akshay. Any technical person is there? There is nobody responding, sir. 1 second.
Smita, there's a message over here that session will be end in 24 minutes. So are you going to extend the same thing or?
No.
No, sir. That is my screen, sir. That
Okay.
is. Yes.
Okay. Akshay, can you hear me?
Somebody has written as text support.
By speaking louder, Asmita is not going to hear you.
Yeah, और नहीं तो क्या? Akshay, Manish, anybody? I think we'll
म्हणजे
go on.
हे आहे ना लिव्हर लॉक गाईड वायर आणि हे चेंज केलेलं कळलं मला गाईड वायर शॉर्ट पण केलं थोडं
Lakshmikant, please mute yourself.
हो सॉरी सर
I was like, he's the one. Yeah. Oh God. Is it? It's coming now. Okay, Aparna.
Go ahead, Aparna.
Yeah. So the previous CT in 2016 had shown features of ARDS. There were pleural effusion, pericardial effusion, and there was just this one more finding of basically there was left axillary lymphadenopathy, like up to 13 millimeters. So this is our present CT. This date is 16th of May. So we are seeing some areas of fibrosis in the upper lobes and more anteriorly, which can be consistent with the post-ARDS fibrosis. And we know that the post-ARDS fibrosis occurs anteriorly as compared to the actual ARDS. There are a lot of areas of inhomogeneous attenuation. We don't have expiratory scans, but I guess that these are some areas of air trapping. So there could be some obstructive airways disease also is what I'm thinking. Again, everything is more in the upper lobes and more anteriorly. The same inhomogeneity we are seeing in the lower lobes also. There are some focal areas of bronchiectasis, and at some areas the bronchi are looking mildly narrowed also. Like for example here, let me just zoom it up. This posterior basal, maybe medial basal segment, we can see that there's some focal narrowing of that segmental bronchus. Plus there are some areas of bronchiectasis. So these are the main things in the lungs. Then in addition, again, those lymph nodes that, one second. The lymph nodes that we saw previously, they have actually increased in size now. So they're up to 18 millimeters and they're probably more in number also, but they're again still confined to the left axillary region. Mediastinal, they are just small in size. But again, these have also actually increased, whatever small nodes are there in the mediastinum. I don't see any lesion in the left breast. In the right breast, there's some asymmetric tissue on the outer aspect. There is also some small lesions in the liver that I can see. So in the left lobe, we can see one small hypodensity here. And one more lesion I saw in the left lobe somewhere. So yeah, this is the other lesion in the left lobe of the liver. So I don't know if some other process is happening. I know it's a long time between, like it's almost 9 years, but slowly the nodes have increased. We do see sometimes in CTD some nodes, but they're usually bilateral and small in size. These have increased. So I think we should actually do a node biopsy for whatever is it, some low-grade lymphoma or something. But the lungs themselves, I think they are more like the post-ARDS sequelae.
Okay. There was esophageal dilatation, Aparna?
Maybe the lowermost.
Upper में भी
Mostly.
था. Just go to upper lobe.
Yes, mild dilatation is in the upper part, yeah.
Okay. The fibrosis remains the same. Only the lymph node increased, right?
No, previously was just ARDS. Now it has become post-ARDS fibrosis. Whether we want to consider hypersensitivity pneumonitis is the other thing with the pigeon exposure and some other exposure that we said. Or whether we want to just take it as post-ARDS fibrosis.
So your radiological diagnosis is fibrotic NSIP?
No, not NSIP. Either post-ARDS sequelae related fibrosis or a hypersensitivity pneumonitis.
Okay, post-ARDS sequelae or fibrotic HP. That is what your impression is. Okay.
Yes.
Now we'll move on. Yes.
Yeah.
Yeah, I'll just share the screen, ma'am. 1 second. Yeah.
Right. So I also gave importance to that recent PGN exposure and with a little bit of air trapping, fibrosis, more on the upper part and all. I thought I was dealing with HP and I gave her steroids, just 2 weeks of steroids and asked her to come back. And yeah, if you can show me the slide before, Asmita. Yeah. So that was her X-ray, and she said she improved dramatically. That was what her symptoms. 6-minute walk test showed a little bit of desaturation. Dyspnea scale has come down, and she was able to walk more. So I was not sure what I'm dealing with, and I'm still stuck. That's why I presented this case in the MDM. So what is the opinion of the MDT?
Sure. You wanted a consensus diagnosis, I think, yeah. Rajan sir and Prahlad sir. We have Lakshmi also. Lakshmi, you just message. I'm not able to read. 1 second. Okay. Could this be sarcoidosis with upper lobe involvement? That is what Prakhar thinks. Aparna, Did you find anything to suggest sarcoidosis on the CT scan?
Not really. I mean, there are no nodules. They're just like a little bit of fibrosis, unless this is some fibrotic form with
And
no
you
nodules now.
specifically told the lymph nodes were localized to the left axilla. That
Yes,
is also
yes.
very unusual for sarcoid, right?
Yes, yes,
One
yes.
localized lymph node. So
Yeah.
no, we are not thinking of sarcoidosis. Now
I think if you see the 2016 or 17 HRCT chairs, which shows ARDS like pattern, but there is a significant pleural effusion. So I think that may be actually a pulmonary edema rather than we can say ARDS, or maybe a combination of ARDS with pulmonary edema. That's number one. And so many days have passed, and lung shows so much amount of decreased diffusion capacity by 20%. The airway shows significant air trapping, and there's alveolitis. I don't think post ARDS lung look like that after so many years. Okay.
If you will lower your camera, sir, we are not able to see your face. Not that it matters.
Okay.
Yeah.
So I'm not in the hospital. So
Yeah.
So the AR is more of pulmonary edema plus minus with ARDS or whatever it is. But the picture of HRCT is not like ARDS sequelae. The reason is that there is a lot of ground glassing is there, a lot of air trapping is there. It's not just scarring. And so many years have passed now. Patients significantly have diffusion reduced and restrictive lung disease. Very unlikely this is. So this is something additional thing which is there. So we have to investigate. We don't know what the lymph node whether will give importance. There's a unilateral lymph node, so it is more important.
Yes. Yes.
And second thing is that even the liver size looks like to be enlarged. Okay, so I don't know what lesions they are there in the liver, but the liver sonography and complete liver function test may be useful to us to assess it. And of course, further investigations are required. Certainly, by giving steroid, we have I got some benefit, but we are in confused state. This is what observation. If we try to give steroid for the patient point of view, and then after some time we are in the dilemma what to do.
Yeah.
So this is a common thing which happens, and it happened many times because the patient may be pushing us to treat us fast. That's the reason probably, and or maybe. So I think at least we should go ahead with investigating that lymph node. Whether to biopsy or not, a sonologist will be able to tell you better whether the island is preserved or not. Okay, so that's one. And second thing, the other parameters like LDH, complete liver function, UHG abdomen will be if patient is very affording. Certainly, a PET scan may be useful to decide about the lymph node this thing. But a lymph node biopsy, a lavage at least, okay, may help us.
Okay. I would just want to add upon that Shobha madam was very nicely have put one picture, even though you told repeatedly that it is a old case. I'll just bring that particular slide, in which she has shown 2017 one X-ray was there, sir, which was also showing those things. If we can see here, like I'm sure that it has progressed, but if we see here, na sir, it is almost like we can see that it is the same picture. So if we see this
2016, if you see
clear,
2017 good improvement, 2017 shows hyperinflation. Diaphragms are flat completely.
But there are some nodular opacities. Yeah. And then this is the lung volume is slightly decreased compared to 2017. So there was something going on. So can it be two dual pathologies, like lymph node is there and this is going on? So my impression is it may not be connected, but lymph node needs something to be done. Yeah.
Aparna, I think when you were projecting the scans is when I think the internet was having a problem for the audience link, no?
Yes.
What was your impression on the scans, Aparna? On the lung windows?
The present one, sir?
Yes.
Post-ARDS and
post-ARDS fibrosis versus hypersensitivity pneumonitis was the thing I was talking about, sir.
So that didn't look like sarcoid at all.
I did not really think like sarcoid, sir.
So then
but sometimes we can have that HP type of phenotype in sarcoid, but otherwise it's not the typical sarcoid.
Sure. Which means I think I would probably consider a biopsy, no, Prahlad?
Yeah, certainly.
Because
we should investigate.
Yeah.
Does the liver is enlarged, Aparna, on CT scan?
Sir, liver is not really enlarged, but there is a lesion, sir. Some
Okay.
focal lesions. Definitely, it needs investigation, sir.
So it is, if you're looking at whether you should treat the sarcoid, I think I'm pretty sure you should, because patient is desaturating on walk. Patient has a low lung function, low vital capacity, low DLCO. So there are enough reasons that the organ is significantly involved, Shobha. But the point is that our working diagnosis? Are we going to work?
That is the problem.
Yeah. And then, the implications of a working diagnosis of sarcoid. I think there are a lot of sites we could potentially biopsy. I think the axillary lymph node would be the safest.
Yeah. I know. Actually, there was a comment from Dr. Kiran from Trivandrum that can be low-grade lymphoma, and we all are considering possibility of that, Kiran. So, point is well taken. Lakshmikant, do you want to add something, or we will move on to the third case? The consensus diagnosis is not possible, madam, at this point of time, and we would like to discuss again with the lymph node biopsy.
Yes. Yeah.
They have a problem in affording a lymph node biopsy also?
No, they will afford.
I think we can get a lymph node biopsy done. I think, her husband is admitted with leukemia in hematology ward. So they are under tremendous pressure.
I understand. Yeah.
Yeah, that's why I had to give her steroids. Otherwise, I would not have given steroids.
Because we could request Ritu to look at those lymph node biopsies, do the special stains. Ritu will do that all. She's done it for us often.
Yeah.
Yeah.
Okay.
Thank you.
So we are doing we will move on to the third case, which is by Dr. Prakhar, and he is, I believe, professor or associate professor in AIIMS Rishikesh. And thank you so much, Prakhar, to be with us.
Good evening, ma'am. Good evening, everyone.
1 second, just give me a moment.
I'm audible, ma'am.
Yeah, yes, you are audible, and please go ahead. And I hope from audience side also they are able to see the slides and listen to us. Okay.
Sure, ma'am. So we have the 65-year-old male who is a BSF force worker. He was a smoker, but he has quit 5 years back. And in comorbidities, he just had a systemic hypertension for which he was taking amlodipine and was well controlled on that. He presented to us with shortness of breath since 3 months, and along with that, cough with expectoration, minimal since 3 months. His shortness of breath had increased from grade 1 MMRC to grade 2 over the last 2 months, and there was no associated features. And cough was associated with mucoid expectoration since last 3 months. That was his total history. Among exposure, he had a mold exposure on the army quarters where he used to live for approximately 3 months, but this happened approximately a year back. No other exposure among CTD symptoms. There was nothing suggestive for connective tissue disease symptoms. On examination and vitals, his vitals was absolutely okay. On general examination, however, there was clubbing grade 2. On respiratory auscultation, there were bilateral basilar crackles, which could be heard. Musculoskeletal was normal. Among labs, his TLC was slightly incremented. Creatinine was 1.32. ALT/AST mildly elevated, and as well as bilirubin. And GGT was also slightly high. CRP was positive. We could not get the quantitative report. Just echo was normal, and there were no features of pulmonary hypertension there.
LDH was not done, right?
No, ma'am. No, not that. Then we went ahead for the serology further. So ANA was negative, ENA panel again negative. Only thing that came out to be positive was a myositis panel with KU59.3+. The immunoplot is represented here. And among HP panel, as he was exposed to the mold, Alternaria and Cladosporium came positive, but this was a very mildly positive state.
Borderline, yeah. Yes. So Mithun, all yours. This report, I'll show you. The ANA was 1:100 and MPO PR3 was negative.
Negative.
And CK was also negative, but myositis panel is showing something like this. What is your comment?
Despite repeated asking, we never complained of any muscular or any skin lesions ever.
Sure.
Basically, myositis thing, it's not a myositis specific. Usually we see with a myositic overlap type of diseases. It is very strongly positive. We have to take it as a significantly positive autoantibody.
Okay, sir.
But
And we,
without clinical features, usually we do these tests when we see the clinical features. In
So,
this,
yes, sir. So basically, we did it after having seen the radiology, which we haven't shown yet here.
Mithun, that control one is 127 3 plus. What does it mean actually?
basically, we have to compare with the control. Control is a sample who has already positive.
So
some
when
other,
it is 3 plus, KU 3 plus is not very high, right?
3 plus is high, no? This is the line. You can see a line. After that line, it is considered 3 plus.
Yeah.
This is not as strong as the control positive.
Yeah. So
you can say that.
Okay, fine. So you always compare with the control.
Yes, always we compare with the control.
Okay.
and what is PMSCL 75 for, Mithun?
That is also overlap.
Both
With the
for overlap.
scleroderma.
Overlap. Scleroderma, myositis overlap.
Okay.
And
Okay.
with this 1 plus, Mithun sir, should we
No.
consider this to be positive?
That is positive, but insignificant. But Q is positive. Whether they have any clinical significance, we have to see the CT and other things.
So Q doesn't fall into category where we have to do PET CT, huh?
No.
Okay. Okay.
Q does come into the myositis associated antibodies, no, sir?
Associated.
MAB. Yeah. Okay.
Okay.
Yep.
So then we went ahead with the pulmonary function testing, and his FVC was well preserved at 88%. His DLCO, however, was low with 54%, and TLC was also maintained. Anything else? And he desaturated significantly from 95 to 85% on the 6-minute walk test.
I think I'll just stop sharing and Aparna can take over. Yeah.
So this is his CT from February 2025. We start from the top. So we can see that there are areas of fibrosis from the upper lobes itself. We are seeing focal areas of honeycombing, some pleuroparenchymal thickening, subpleural reticulations, a lot of architectural distortion. It's slightly asymmetric with the right lung being more involved, but definitely left lung is also involved. There is some involvement of the upper lobes also, but definitely it is having a lower lobe basal predominance, more reticulations, more traction bronchiectasis and architectural distortion. Again, in the lower lobes, there is a asymmetric right more than left. So in addition to all these fibrosis, traction bronchiectasis, focal honeycombing, we're also seeing a lot of areas of ground glass opacity, especially in the right lower lobe. I'm just trying to think that history of only 3 months, whether that is correct or means whether he already had something baseline and now the 3 months, is this ground glass is that why he's presented with a relatively shorter history? Is this some kind of acute exacerbation or some infective superimposition on the background ILD, which is like fibrotic? So lower esophagus, very mildly, it is dilated. And one more point is in the right lower lobe, there is one nodular area within that area of fibrosis. So I think we'll have to keep that on follow-up. Again, I mean, we know that they can develop malignancy, so we'll just keep that on follow-up. Otherwise, main pulmonary artery is not dilated and there's no significant lymphadenopathy. So overall, I think there is a fibrotic ILD in the background, which probably he was having some form of subclinically it was involved, and all this ground glass is looking something active is going on, and maybe that's why he's presented with this relatively shorter history. Maybe that is fitting with the clubbing and everything else also clinically that we are seeing.
Okay, could be. However, he didn't have any infective features for the last 3 months or even prior to that. So that's
some
that could be
active
possible. That
exacerbation maybe then
could be. Could be.
Okay, we have only one CT, huh?
Yes,
only
ma'am.
one
We only
CT,
have
only one.
Okay. And your diagnosis on radiology will be?
Maybe like a fibrotic NSIP or probable UIP with some maybe like an acute exacerbation.
Okay. Fibrotic NSIP bar UIP with exacerbation. Okay, fine.
Ma'am, Aparna ma'am.
Sorry.
Since
yeah.
No problem, ma'am. Since his HV panel had come positive, is there any feature in this CT as which could suggest that this could be a fibrotic HV?
Yeah, I mean, that could also be having that, but it is having definitely that lower lobe predominance. which is little atypical, and we're not really seeing that much of air trapping or any ground glass nodules.
In fact, I think we do not have any amount of air trapping, I guess, ma'am. Is it so?
Yeah. Okay.
Okay. So we went ahead for a sputum examination to rule out for certain infections, which came out to be negative. And then we went ahead for a BAL and TBLB in this patient. The BAL was monomorphic 100%, and these are his TBLB images.
So unfortunately, I actually tried to contact Ritu madam, but she could not
Yes,
show me what exactly. But we can make out that there is some, because so many things has happened. So all this blue looking is the lymphocytic, isn't it? That is what
yes,
we
ma'am.
can know. We know
Yes,
it
ma'am.
that much, and there is architecture distortion that we can very well make out in the slides. Peribronchial metaplasia also is seen because we can see here somewhere this thing, and granuloma is something which we all tried to make. She had mentioned ill-formed granuloma, which was not mentioned by your
Yes, ma'am.
pathologist, right?
Yes,
So,
ma'am.
so that is
So I
what
think
is a new finding, which I believe this is looks like a
on the
granuloma. This
left
particular, yeah,
lower
this particular.
second, I suppose, is something which is looking like a granuloma, but that is something which
So this is
prevented us
more
from.
like granuloma, na Prakhar, on the right side. This
Yeah.
particular rounded thing is look like ill-formed
That
granuloma
seems
to
to
me.
be a lot of cell infiltration. In fact, on the left side, the lower one image, where your arrow is, if you can move it up a little above, and to the right,
This one you want?
towards the, no ma'am, to the right. Yes, ma'am, this area, just below it. Possibly
Okay.
this is something which ma'am reported to be an ill-formed granuloma, I
Sure.
suppose.
Okay. I don't
But
know. I'm not sure. Yeah.
having missed that on our
So
pathologist
her
report.
comment was like this.
Yes, ma'am.
That there is architecture distortion, there is microcystic changes, peribronchial metaplasia, and ill-defined granuloma, and histopathological diagnosis of fibrotic HP, because she could not find any findings of UIP in that. That is what,
Moreover, she
because
could find a granuloma, I think.
yeah,
That's
that
why
is
she
why.
moved more towards fibrotic HP. And that is where we were stuck. Because without granuloma, we were just about at the diagnosis of. This is the report which our pathologist reported. It was a private lab reporting.
This is a cryobiopsy?
Yes, sir.
Oh.
Okay, so your questions
So
was...
my question back to the panel is whether, because we didn't have that granuloma by then, so I don't know. If we have a granuloma, I can then label this as a definite HP in that case. Otherwise, my questions were whether it's a fibrotic HP or is it a myositis scleroderma overlap associated ILD or overlap of fibrotic HP along with myositis scleroderma, since the myo panel has also turned out to be positive. And based on that, what would be the preferred management strategy for this particular patient?
The biopsy findings have sort of made me a little more confused with those ill-defined granulomas. But I would have till Ritu signed off on that biopsy, I would have thought this was an idiopathic inflammatory myositis with ILD.
True,
and
even the radiology is not suggestive of fibrotic HP.
Yeah, the radiology is not classical, and you can get a little bit of honeycombing. They do progress slowly. This is probably an acute exacerbation right now in which the patient has come.
Yeah.
Very difficult. And I didn't understand your BAL. 100% monomorphic. I mean, are there no macrophages, nothing, Prakhar?
Yes, sir. As per our pathologist, that was an in-house pathologist. They didn't report upon. They usually report it as the percentage of neutrophils and lymphocytes only.
Right.
And whatever they seem to be predominant, they usually prefer to write as either they give it as a proportion, 40-60 or something, or they move it towards 100% when the levels go above 60%, 70%.
Yeah, it's a little unusual BAL report. I'm not sure. Is that, Prahlad, how your team reports a BAL?
No. That doesn't give much information.
Yeah, we're not informed.
Markers were put on the tissue. Very nice biopsy. So happening biopsy, it looks like something is there going on. And lot of, it's a cellular tissue, right, Sujit?
Very
lot of cells are there in the entire
tissue. I do think the management may not change much, but whether we are dealing with inflammatory myositis or HP is the tough one. And so it would have been nice to have Ritu here to really show us what was going on HIPAA, because they were just these photographs, you couldn't make out much on these photographs.
Yes.
Is there any way to magnify those photographs to show us what she was saying, Asmita?
I'll try, sir. But before that, Mithun, this KU, because this ground glass opacity is a very classical of RP-ILD also. It starts with that. So, is there any chance that we are dealing with something like that? Because that is the only new finding which we cannot explain with the current this thing. So,
Just before Mithun starts, I was just wondering, how is this a 65-year-old border security force? I mean, their retirement age, I thought, is 60. Still working with the BSF, Prakhar?
No, sir. He's, I think he is working on a part-time as something.
Okay.
He was earlier as a BSF.
Right.
And
he's
in the recent quarter, yes.
Yeah.
Yes, he's
been a heavy smoker earlier. So there could be a smoking-related lung fibrosis also as a differential. Would that also come as a differential, Aparna?
Yes, sir. Basically, I mean, in that UIP and all those things are also smoking related. So I guess
he has grade 2 clubbing as well.
Yeah.
Are they, these cells are lymphocyte, neutrophils? What type of cell?
Lymphocytes, no, sir.
All lymphocytes.
It looks like more of lymphocytes than this. I believe this it's enlarged, sir. Can you see now? Better than before. I can just do this much.
If you can go on to the 14th image, ma'am. I don't know whether it's a granuloma. I'm just guessing based upon the character of it.
But that doesn't matter. Now, granuloma is like one part only. And
Yes,
one granuloma does not matter, right? We cannot make only on the basis of one granuloma.
We shouldn't, yeah.
Yeah, because we should go by overall. And then this is like, how is the patient doing, Prakhar? Is he worsening?
Quite well, ma'am. No, ma'am. He's walking to the OPD and he's doing quite well. He's planned for a MRI thigh on 30th.
I don't think even Lakshmi is convinced. Lakshmikant is convinced.
Yeah, he told it looks more like myositis
connective
related.
tissue disease.
The only problem was that we didn't want to believe that it's HP. We were also inclined towards IIM diagnosis.
Yeah.
No, Mithun, you were saying something.
No, if there is a lot of granulomas, then it is
lot of nahi hai. Only one ill-formed granuloma. That is what she has written.
Only one.
Then very unlikely, no?
Because COO antibody is also not very common. We rarely see these COO antibodies, but it's a classical, well-described antibody seen in myositis scleroderma overlap. But usually in ANA also, IFA also, it should be positive. Usually we see like that. There's a definite COO pattern in ANA immunofluorescence that is actually absent in this case. Here,
and so COO antibody, is it associated with the RP-ILD pattern usually? I think
no.
It's very infrequently.
Not classical antibody. Usually these overlap syndromes have a good prognosis in general.
Okay.
Usually respond to steroids.
Usually subacute to chronic. See, even on biopsy, whatever description I could go through, there is rapid transition from acute inflammatory process to absolutely normal process. There are no fibroblastic foci. And whatever we could see, there are some distorted airways, small airways or bronchioles which are dilated. And bronchiectasis is also quite evident on CT. So the process is both acute and chronic. That is why he is not very symptomatic despite having hypoxia, which is again a pointer towards subacute to chronic process. And TICU is classically associated with the same subacute to chronic process. This is likely to be very progressive disease, relentlessly progressive disease.
Yes.
So objective monitoring will need to be very, very careful, and change in treatment decision will need to be very careful. If we end up believing HP, then we will not go beyond MMF with this patient. But if we believe that this is autoimmune, we might not limit ourselves to MMF alone, and we might go beyond that.
I agree. I think it's working diagnosis, connective tissue disease, ILD,
Yes.
IIM, with a low confidence HP as a second option, and probably we should have Sharda or Ritu on such cases with the path next time.
Yeah. Low confidence of HP, but unlikely na, because he left his job for so long na sir. Now presenting as HP is
Also,
not going to.
And the amount of exposure was also not too
Yeah,
much
it
to
looks
having
like that.
explained.
We have got our answer. And one more doubt, Mithun. Suppose if we all agree for the diagnosis, won't you treat with steroids first?
Means steroids
मतलब
alone.
yeah, मतलब initial steroids of methylprednisolone of pulse. Would you start because GGOs and all by looking at that, or you would not pulse?
Pulse depending upon the patient clinical features. Severe dyspnea, then you have to give. Otherwise, pulse
You will just
versus oral steroids 1 milligram per kg may not make much difference. No?
sure. Okay, fine.
Yeah, so somebody who comes in respiratory failure only we might consider giving pulse.
Pulse.
For
Okay.
somebody who is having being evaluated on OPD basis for say a month or two, possibly just going with oral corticosteroids and mycophenolate will be a way to go.
Correct.
Sure. Thank you, everyone.
Yeah, 1 second. I'll just stop.
So presently we have started on steroids. So I would then add upon MMF on his next visit.
Yes.
Yeah,
Sure.
the fourth case
And
is from Dr. Ashwati from KIMS Trivandrum, and over to you, Ashwati and team.
Good evening, ma'am. We shall proceed with the case 4. This is a 26-year-old lady who is a media journalist. She presented to us and she was asymptomatic till 1 month prior to presentation. She had complaints of heaviness of chest, right-sided, for the past 1 month, associated with cough and scanty blood-stained sputum of 3 days duration. There was no other associated respiratory symptoms. She was on treatment for endometriosis and hypothyroidism, and she also gives a history of chocolate ovarian cyst excision 2 years ago. There was no history of drug abuse, smoking, or any high-risk behavior. On examination, she was alert-oriented. Her vitals were stable, with BP was 110/60 millimeter mercury, pulse rate was 90 per minute, and saturation was 98% in room air. On percussion, evaluation of the respiratory system, on percussion, a hyperresonant node was noted over right mammary, infraclavicular, intraaxillary, interscapular area. And on auscultation, the breath sounds were diminished in those corresponding areas. Other system examination was within normal limits. On evaluation, the routine basic labs were fairly normal, with the total count being 12,000.
Aparna, I'm sorry, but we have very limited time, so you will be just telling us positive findings.
Okay.
Is it okay? Yeah, please go ahead and be strict to crisp presentation. Okay.
The routine investigations laboratory-wise was normal, and we took a chest X-ray. And the chest X-ray.
We'll see the radiology later on. Just tell the relevant positive findings now. Or you want to go to CT scan first? Then we'll go to CT scan.
Yes,
Okay.
So this is the CT, and what we're seeing is there is a large hydropneumothorax. Let me just put lung window. So there is a large loculated right hydropneumothorax with multiple septations also seen. And the underlying lung is showing some areas of collapse. Within the hydropneumo, there are some very high density areas which may be like blood. This is like high density.
Yeah.
So that may be like hemorrhage also is there. So fluid is there, blood is there, and air is there. This is the collapsed right lower lobe. And in the lungs, in the right lung, because it's more part of it is collapsed, we're not really seeing any other lesion. But in the left lung and in both epices, actually, there are two small cysts that we're seeing in the epices. And in the left lower lobe, there's one cluster of cysts with some thin internal septations that we are seeing here. This is one focal area with multiple clusters of cysts with septations. and another one cyst here in the posterior basal segment. Now in the abdomen, in the kidney, we are not really seeing any lesions. In the liver, I saw just one very small focal spot, which is looking low density. I mean, whether it could be fat, but it's a very small focal spot. So difficult to say exactly the density. Otherwise, there's no lymphadenopathy and no other lesions that we are seeing. So basically hydropneumothorax. So what are the thoughts that we can say? Because we are seeing like blood density also, like high density areas. And you gave the history of this endometriosis. So whether that could be one possibility. And but this is one single episode and not multiple catamenial like that you have not mentioned. But because I saw that high density and you mentioned the endometriosis, I'm just keeping that as one possibility. Other thing is whether there is some kind of cystic lung disease, of which I'm still considering LAM also, although it is not very typical, the lung findings, but because in the liver, one tiny probable fat density like area is there, whether it could be LAM and whether one of those has ruptured and caused the hydropneumothorax. Third thing is whether it is an infection, is it like some empyema, and is that not really blood, is that pus or something that is like layering there? Yeah, so these are the main thoughts that I'm having. Yeah.
Very large cyst on the right side, right, Aparna?
I think this is part of the loculated hydropneumothorax.
But you are seeing multiple septations inside now.
Septations are there.
Yeah.
Yeah.
Okay. Okay. So you feel it is some cystic lung disease bar LAM or bar some infection, right?
Yes.
Okay.
Or that endometriosis is the third thing because of that.
Catamenial kind of.
Is
Okay.
it
Okay.
something
Fine.
like
Fine.
that?
Fine.
Yeah.
Got it. Got it. I'll just start sharing my screen. Yeah. Go ahead, Aparna.
A multidisciplinary discussion was done between the radiologist, the cardiothoracic team, and the medical genetics department, and further workup was planned. Our differentials at that time were thoracic endometriosis and any cystic lung disease, and alpha-1 antitrypsin deficiency, or any other genetic disorders. In order to rule out LAM, we did a vascular endothelial growth factor, D as well. And prior to if thoracic endometriosis syndrome was our diagnosis, we needed a definitive diagnosis, we needed a biopsy. And before planning for a VATS, we proceeded with an advanced PFT.
Okay. Yeah, go ahead.
And we decided to proceed with the VATS. And post procedure, the lung expanded well, and the repeat X-rays are also shown.
Yeah, so in this, Ritu madam had seen the slides, and what she commented was it just looked like lymphocytic pleuritis. She could not see no granulomas, and she didn't give any comment about anything. Like she just told it is lymphocytic pleuritis. That is what her report is on this slide.
And we did not for our also here also her histopathology was reported as lung cyst with normal cuboidal epithelial lining, and the positive finding we got was the genetic test which detected FLCN gene mutation, and thus our diagnosis became Bird-Hogg-Dube syndrome. And we moved on with screening of her family members, her mother and sister, and her sister also the FLCN gene mutation was detected.
Okay. Shruti, did you have any question to ask? Because I didn't see it in the slides. Okay. You can go ahead. Yeah.
My first question is, ma'am, from the CT.
We can't hear.
Louder, little.
Yeah. Yes. Yeah. From the CT, can we narrow down any other diagnosis?
Can you log out from the computer?
I think it's echoing.
Yeah.
So we have a diagnosis which is great: FLCN gene mutation, cystic lung disease. This is BHD syndrome. What's the question?
Yeah, from the CT, can we narrow down any diagnoses?
like just cystic lung disease, or can we say that it could be a specific cystic lung disease?
You have narrowed it down with the FLCN gene mutation. There's no need to narrow it down further. No, but is there a specific concern you had on this?
No, initially we had, but we got a report recently. So finally we arrived at a diagnosis, and we would like to know what can be done for this syndrome. Is there any treatment that we can offer other than surveillance?
So we have 3 patients in follow-up on this. So I'm not I wouldn't call myself an expert, but three patients is a fair amount, and they're all doing pretty well. One was thought and suspected to have a LAN, and she had was advised not to be pregnant, and she actually decided she wants to go ahead with the pregnancy, even if she died after the pregnancy. And we supported her in that decision because she was so keen to have the pregnancy. She survived the pregnancy. Then her sister in Canada developed a pneumothorax, and then the FLC. And this was many years ago, almost 15 to 20 years ago. And then the FLC gene mutation was done there. She's remained very stable, but the cysts can progress very slowly. There is no treatment. I would strongly do early pleurodesis in such patients, a good thoracoscopic fluoro. Did you do a pleurodesis at the time of the?
Yes, after that, pleurodesis was done.
Very good. So I think that's what you need to do. In fact, one of the patients, Prahlad, and I mean, he had admitted her once when she had a pneumothorax. On one side, the pleurodesis was done at his hospital, and the other side, it was done with us. And she's doing well so far. I don't think any screening of the relatives. Yes, I understand that the penetration is not very high into the family, but it can occur. So it may be a good idea if they want to be screened, but then you have to do genetic counseling before that. And I don't know. Where did you get the genetic mutation tested, Aparna?
In our hospitals.
At Trivandrum.
Yes.
Fantastic. Prahlad?
Yeah. I think we should give importance to that genetic counseling, genetic test, FLC gene. We should test the family, then it has to come positive. Around 20-30% of the patient. But needs very close monitoring for lungs as well as kidney.
Yeah.
So this radiology, already she's a 26-year-old girl, and already there's significant damage in the lung. So can we expect rapid progression in VHT very commonly? Do we see a lot of rapid
None of the patients I've managed have rapidly progressed. None of these 3 are progressing rapidly. They're pretty stable.
Okay.
And
does the patient had a skin lesions? No.
No. We had done a thorough examination. Even the dermatologist had a look, and there were no skin lesions.
No renal lesions also. Can I ask, when you did the VATS, was there blood also in the pleural cavity?
Cysts. It was a blood-filled cyst.
Blood.
Hemorrhaging. But there were no features of endometriosis.
Excellent. I mean, really nice case. We should discuss this more probably during the webinar. And we are having a webinar on July 18th with Nishant Gupta on cystic lung disease. So do tune in on the 18th of July for that web meeting. And we put up this question on her case as well. Sure.
Thank you.
Thank you, Ashwati and Aparna. We'll move on to the last case.
So the last case is a lady, again, the same age as the last lady we just saw. 22-year-old single lady, never smoker, not active in sports, physical activity. Prahlad has seen her once as well. Postgraduate student in Hyderabad. She complains of persistent cough, and since 3 years. And she used to walk about 10 kilometers a day till August 24, but then started getting increasing breathlessness on walks, lifting heavy weights, and bathing and changing clothes since the last 6 months. I think Lakshmikant, I would like your views on this patient because Prabhu Desai and I have both seen her. Prahlad may already have his view, but this girl could walk about 10 kilometers a day, as I said, till about 10 months ago. She has a little forgetfulness the last 6 months, mild eye dryness, irregular menses since her menarche 9 years ago, no joint pains, no early hair graying, frequent dental infections since childhood. Saturation's 98% on room air, but uses 2 liters per minute on ambulation, high arched palate, and she has a normal echo. She's been treated on prednisolone 5 milligrams a day for the last 3 years, MMF 500 mg twice a day for the last 6 months, and pirfenidone 800 milligrams 3 times a day for the last 2 years. And then she was advised by her pulmonologist to take rituximab in December 2024. 2 doses were given. She feels a little better. Her ANA immunofluorescence negative myositis blot shows a strong Rho52 positivity, and a whole genome sequencing has been asked for, which is awaited. Next slide. And these are her PFTs over the last 3 years. And you can see that she's lost about half her lung function in the last 3 years. DLCO really dropped. It picked up a little in the end of July of last year. She couldn't do a DLCO maneuver in June this year. And her 6-minute walk test was pretty decent a year ago, but now obviously she's declined. I mean, she's dropping saturation a lot more than she was last year. And so maybe Aparna would like to show us the scans in the last 3-4 years.
Sure. So I'm sorry, for some reason I'm not able to put them side by side. So I'll just go and one of it I'm not able to open. So this is 2020.
Yeah.
I think it's kind of looking like this is when it kind of started. So we can see that what we're seeing mainly is some kind of opacities, bronchocentric peribronchial kind of opacity, some mild bronchiectasis or small cysts in the upper lobes. But many places we are seeing something around the bronchi. The peripheral areas are kind of clear. Again, here, all these we are seeing something, some airway centered kind of opacities are there. So that's how it was looking at that time. Maybe we would have thought whether it's like some form of organizing pneumonia because it's bronchocentric kind of focal consolidations and small patchy opacities. Maybe vasculitis would be the another thing that at that time, at that point, we would have thought of maybe. So that is 2020. And then we have many in between. So 2022, I'll just show you next. So sorry, it's just taking a little while to load. Basically, it has it is kind of progressing over time. I don't know. It's there are so many scans and it's the whole system is hanging whenever I try to open it.
Right, open, yeah.
Yes. Now it's open. So I'm just going to the lung window. So we can see that there's definitely that same areas all around the bronchi are like it's progressing, this becoming more fibrotic and they're all becoming cysts are developing, cystic areas, traction bronchiectasis. Again, periphery are spared. It's all around the airways. That is the main finding that we are seeing. The lower esophagus is mildly dilated, but maybe upper also is mildly dilated. So now this is the latest 2025, which has much more like very much progressed with multiple large cysts that we are seeing in the upper lobes, more fibrosis, more traction bronchiectasis, many more cysts developing throughout, lot of peribronchial fibrosis. And it's like the entire lungs are quite significantly involved. So what could it be is I've just put together all the, just for the comparison sake, just the upper lobes alone, I just put together just to show the progression. So 2000, 2022, 23, 24, 25. So definite, significant, relentless progression is happening.
So I asked her when her pulmonologist saw her 4 years ago why a biopsy wasn't done. And she says that she wasn't advised a biopsy and she was just to take immunomodulation. I'm not sure if she was advised and she refused, but I thought it would have been useful to do one that time. Currently, what would you put this pattern into, Aparna?
Yes, she's very young, so whether some form of genetic thing that we have to consider. And
Yeah.
you said that you've sent for the whole genome
Sequencing has been
sequencing we're
started.
waiting.
Yeah, I
So
think.
any of these, whatever surfactant or any of
Yeah,
those kind of
surfactant.
problems. Other thing is this entity that people call this airway-centered interstitial fibrosis, because it's all really along peribronchial and bronchocentric.
Right.
But again, I mean, different entities can bring this similar kind of pattern, I guess, but whatever
Yeah.
it is definitely progressing fast.
Can't we call this as a progressive bronchiolitis with organized pneumonia with fibrosis?
It looks more like Sjogren involvement of lungs, sir.
Yeah, because it initially presented like some OP pattern, then
Yes,
lot of hyperinflation. Every time is peribronchial. And there is a cyst formation is always there when there is a obstructive bronchiolitis or bronchiolitis. The chances of getting cysts are very high. So can't it be called as this pattern, like a progressive OP or bronchiolitis with cystic disease? I'm just asking. This is just for when we call this such pattern.
Yes, sir. It looks like the same thing. I would possibly bet more on Sjogren syndrome. Sjogren syndrome with all lung involvement, both organizing pneumonia as well as airway-centric involvement.
So they have generally worse prognosis compared to lung fibrosis.
Yeah, so she is likely to do well with rituximab even now, and if she sort of maintains whatever she has now with low flow oxygen, if she is active, possibly we can delay lung transplant, but we are possibly looking at eventually considering lung transplant for her.
Sir, have you done the ANA profile in this patient? ANA profile?
Yeah, we've sent her actually ANA profile out when she had to go back to Hyderabad. So we're waiting for that the whole thing has gone out.
And the Schirmer test, Schirmer for the dry eyes, because she has this mouth, then they'll carry something.
Yeah, but I don't think we had time to get all that done. I don't even think she has met a rheumatologist so far, So we just thought we'd get the the autoimmune workup done. And if I recollect, yes, this row 52 was strongly positive. Lakshmikant, how do you read anything into that?
Row 52 in the myositis panel, no? In that you don't have this SSA, row 60 and row 48, which is, if that is, row 52 is positive along with row 60, then it is very suggestive of primary Sjogren syndrome.
Okay.
Therefore, we need to have the ANA profile. Because
Yeah,
ANA,
but
IFA can be, yeah.
Yeah, so but I have quite a few patients actually who have isolated row 52 positive.
Yes. That
They
is
have
the
classical ILD. They respond to immunosuppression, and one of them is off immunosuppression now after completing almost 5 years of treatment.
I want to say that these isolated row to say isolated row 52, you need to have ANA profile, because the prognosis and the treatment is slightly different. If isolated row 52, it is like a myositis associated antibody. Whereas it's if it is associated with Sjogren, it's a different thing.
So you're saying the prognosis with Sjogren's will be better?
Not better. We need to Sjogren. We can expect something, no? Like dryness, and rituximab. There's a good chance that it will work in Sjogren.
And so she is better with rituximab, but lung function, I mean, physiologically she has not improved neither on the scan. She's just clinically a little better. So I think, Prahlad, when you last saw her, you said to go ahead with the second dose, right?
Yes,
After
yes.
6 months.
Yeah, she was clinically better.
The length can be called LIP or mixed something lymphocytic. LIP we can.
Not very, I'm just thinking not very typical, I think. But
I think
yeah,
Prahlad sir, what mentioned makes sense, right, Aparna? Because it started with peribronchial and then
yeah.
obliterative bronchiolitis, which is converting into cyst, is most likely possibility here rather than anything. And if we go into that direction, it explains everything.
Correct, because cysts are there in area where there is no fibrosis around.
Yeah, no fibrosis.
So
And
cysts are in
earlier
different
those,
area. Fibrosis is in different areas.
yes, yes,
So
yes. And
fibrosis is progression of organizing pneumonia, and cysts are secondary to obliterative bronchiolitis. But
yes.
again, obliterative bronchiolitis is also seen with Sjogren, and organizing pneumonia is also seen with Sjogren. So this is looking more like Sjogren related involvement, including that dental involvement, which is going on for very long. Primary Sjogren, which came in very early.
Isn't in Sjogren people do this immunoglobulins and all?
Immunoglobulins usually will be high. Usually IgG will be usually high.
Yeah, that's what.
And
So,
usually in Sjogren, what we do is hydroxychloroquine also have a role, not directly for the lungs, and sometimes we combine with mycophenolate mofetil. Like if it is Sjogren with myositis, ILE, usually it will be refractory to treatment. And most of our autoimmune like RA, SLE, usually rituximab is not given as a monotherapy. We usually combine with mycophenolate or some other DMARDs. Therefore, if it is Sjogren, if this patient is not improving completely, or we can consider adding mycophenolate along with rituximab.
okay.
Oh no, for this patient, we may not be able to expect improvement now. What is remaining is possibly just prevent
Salvage.
further progression and delay. Improvement may not be possible in this patient. So improvement may not be the goal. If it is achieved, it is good. But even if it is not achieved, that cannot say immunomodulation is actually failing and is not required, or we can take it off.
Only I want to say in SLE, Sjogren, RA, no? Usually monotherapy, rituximab, instead of monotherapy, rituximab, we may combine.
Yeah, combination is okay, yes.
Yeah, you are right, Mithun.
Within one question in the mind. Now, when such patient comes in practice, you have received steroids, a full dose of mycophenolate, rituximab, and the workup is not done adequately. So I would like to ask you, which medicines affect the workup really significantly? Means, does your autoantibodies are changed because of these drugs, or whether it remains still high?
Some autoantibodies will change. Like MDF5 can become disappear with treatment, but whereas Rho52 anti-SSA will persistently positive. Even if you give rituximab for 2-3 years, it will be positive because it is considered that they are produced from the long-lived plasma cells, whereas MDF5 are produced from the short-lived plasma cells. That's the explanation for this.
And the markers like ANA, dsDNA.
dsDNA will change with treatment. dsDNA will change with treatment.
Okay.
Should we
it becomes very difficult to interpret.
I will put.
For SLE, ANA will be positive. If dsDNA usually positive in SLE, they will have other features. Therefore, diagnosis-wise, it may not be an issue.
But in SLE, you do C3, C4 also, no? For activity.
SLE, yes.
So maybe we could consider a lip biopsy then, you think, just to be, we'll consider that at least. And the first question, I think Prabhu Desai has answered, and I think Lakshmi agrees with him. Anything on these frequent dental infections, frequent root canals since childhood? I mean, she told me this. Does that make us suspect anything else here, Lakshmi?
I think it's part of same things, dryness of mouth. We'll have to possibly go into the history of Sjogren's little more.
Okay.
No, whether IgE was checked, hyper IgE syndrome or Job syndrome or anything, but that is a typical facial.
That will have the skin lesions.
Yeah,
Skin lesions,
typical
yes.
facial appearance will also be there. Yeah.
I don't think.
I don't think this fits into the hyper IgE syndrome. I can check that, but it didn't, no, Prahlad? I don't think.
Oh, yeah, they have typical faces, sir.
He did have a marfanoid-like features, though.
Yeah.
He had a high arched palate, but her echo was normal. There were no valvular issues. And then I think there was also a suspicion of Ehlers-Danlos syndrome. I have never seen a patient. Anyone has seen a patient?
Yeah, Ehlers-Danlos syndrome is associated with cystic lung.
Yeah,
Yes,
that will be. Yeah.
You can see it with cystic lung,
yes,
but
yes.
is there a genetic mutation we do?
Yes, there is the genetic marker. We have one Bhavin has seen one of my patients.
Okay. We'll find out on the whole exome sequencing whether
Yeah.
that is perfect. Yeah. Thank
Yeah.
you. I think
We,
in the next
we'll
2
like.
years, I see a clinical geneticist being needed in the.
Yeah. But that is a very rare entity. If we are able to get one, we'll try. I will try my.
We'll find one. I'm sure
We'll
we'll
find
find
one.
one.
And there is little change in our not next time. Next time we will have on 27th of June only, and we have really very very different cases today. All were of different diagnosis and very good discussion. Thank you so much, everybody. Until next time, take care.
Thank you.
Thank you.
Bye.
Thank you.
Thank you,
Thank you.
everybody.
Bye.
Thank you.